sell a lot to
We are live.
the bigger healthcare.
We're just holding on for a minute or two before we start the webinar.
Yeah.
Please check in. Let us know where you're watching from.
Approved device.
So is it like the Medfine or is this different?
So it costs more, but we're also offering digital.
I hope we're live.
We'll qualify for the extra.
Yeah, it's maybe just you and me.
Okay.
We'll be capturing what side what happened. We'll be providing two therapies. So therapy from keeping you to move over, number one. The therapy number two is little buzz. If you're trying to move over.
Okay.
And then we have a bunch of compliance information.
Okay. That's interesting. Yeah. For sure.
He knows.
Yeah, I'm surprised I'm not seeing anybody there.
Gary Kreiner. They're all temple guys that came out with like Jefferson guys. I'm sure he knows them. Small world.
Yeah.
Especially in Pennsylvania.
Yeah. Thank you.
Do you want me to put up my slides or you want to just leave it?
No, not yet.
Okay.
There we go. Okay. Just making sure everyone's there. Giving a few more people to check in, and then we'll get started with today's webinar. Let us know where you're visiting, where you're viewing the webinar from. I see Stephanie Davis from North Carolina. Neil Williams in Dallas. There we go. Coming in from parts unknown. Hello from Pia. There we go. He might be on a delay here. Okay. So we'll just give it another minute just to make sure that the audio and video is okay. And then we'll start the webinar. Great. Seeing lots of comments. Great to have you guys here. All right, let's get started. Hi, it's Michael DiDomenico with Sleep World Magazine. We are live actually here at the American Academy of Dental Sleep Medicine meeting and doing it here right from the booth. And it's great to have you along. Hopefully there's not too much background noise, but just to let you know, we have to do this up front and I'll drop this back in. This meeting is accredited for MDs, DOs, NPs, PAs, and dentists, and also for respiratory for sleep technologists. For CME and for the dental credits, at the very top of this chat is the CME accreditation link that has to be provided before we go live with this CME activity. So it's up there. I'll post it in again after I'm done with my intro for Dr. Jaffe. If you have questions during the webinar, feel free to drop them in the comments. We're going to feed those to Dr. Jaffe live to make this more interactive and answer those questions. So as he takes breaks and in between, I'll interject with a question for him so we can keep that going and we don't have to wait till the very end to do all the Q&A, although we'll do questions at the end as well. So at the end of the webinar, we'll do that, but feel free to drop questions in and we will handle it that way. And again, I'll drop in the CME piece. So today we have our webinar on positional sleep apnea. Dr. Fredric Jaffe has been a sleep specialist for the last 20 plus years. He has practiced in large academic medical centers and moved to private practice. He has treated thousands of patients with sleep disordered breathing. He believes that giving patients multiple treatment options is the best way to treat sleep apnea. Dr. Jaffe, welcome.
Thank you, Michael. I appreciate the opportunity to speak to all of you from, it looks like, around the nation. I'm thrilled to have this opportunity to do so. So let me just share my screen. And I think it's important when I talk about positional sleep apnea that you're looking at a small piece, but an important piece of sleep apnea treatment and diagnosis. But I could sit here and give you 50 slides on probably 20 or 30 studies on positional sleep apnea and easily put you to sleep within 20 minutes. But I want to take you on kind of a thought process and a journey of understanding where we are in sleep apnea, what the physiology is, and what we can do about it, and why certain therapies may or may not work, and where positional sleep apnea fits into your whole treatment algorithm. I don't have any commercial disclosures, but I have been involved in positional device research, so it's an interesting topic to me. We'll talk about the prevalence of sleep apnea because I think it's important to understand, and I'm glad that we have people from around the nation because I'm going to show you some maps that may be interesting to you about where the risk factors are and how prevalent they are. We'll talk about a little bit about the physiology of the upper airway, and we'll talk about treatment options related really to the upper airway, but also globally. And then we'll talk probably for the last third of the talk about positional sleep apnea, the physiology that's been discovered, the epidemiology, and what the treatment is. And you'll see the different devices that people have used, and are they effective? Also, a little bit about the cost, because I think that's a contributing factor to sleep apnea treatment. If we go back almost 25 years or even 30 years, we look at the prevalence of sleep apnea. I'll put up a laser pointer here just to highlight some stuff. This is old data that we were looking at men and women with sleep disordered breathing overall were only 2 to 4% of the population respectively. But that was, we knew it even at that time that was underdiagnosed. And we see the percentages as you get a little further throughout the last century and the beginning of this century, that the epidemiology was all over the place, but still really underreported. This was revised in 2013 and is due for a revision. If we just look at moderate to severe sleep apnea with an apnea-hypopnea index of greater than 15, and we'll see why that's important, you see that you started to see much more of a population that is suffering with this disease, from 2% to 10%. And if we look at just the population of this country, about 335 million, you're talking about 30 plus million who have been diagnosed. Now that number is probably bigger with respect to unrecognized sleep apnea, but you even see that women are starting to be more and more reported as well. And the increase over the past 2 decades has been close to 50%, and I expect that not to be as such a rapid increase, but to continue to increase linearly. I always like these slides as put out by the American Academy, and it's just, when you look at undiagnosed sleep apnea, you see all the things that it contributes to and how it has a drain on our economy. You know, 150 billion in 2015, and it's probably higher now because we know more about the effect on comorbid diseases, motor vehicle accidents, and lost productivity, missing days from work. So it's really a huge health crisis. And I think we've been very one therapy centric, and saying to people, you have sleep apnea or not, in the sleep community. But I'll see if I can change your mind today. If you look at treatment criteria, this was from the Heart Health Study, that we agree that everybody should be treated with an AHI greater than 15 in moderate to severe circumstances. But if you're mild, we saw a mortality benefit in those with excessive daytime sleepiness, with cognitive difficulties, and other comorbid conditions. So when you hear from patients that, oh, I only have mild sleep apnea, do I need to treat it? I think you're very well served to tell them there are a lot of things that if you're having problems with your memory, if you're tired all the time, if you have other comorbid conditions, this needs to be treated. I think mild sleep apnea sometimes is a misnomer, you know, and people think, well, I only have mild, you know, it's like having mild hypertension. You still have a risk of mortality. So what's the epidemiology really? And this starts to get into the crux of what we're going to talk about today. Ethnicity certainly has an effect on this, with mild changes in airway anatomy. We've seen it in different populations. We've seen men and women differences. But the major risk factors are obesity, and age as you get older. The influences from the brain and the musculature are different. And a big thing is oropharyngeal anatomy. I know we have some dentists on here that look into people's mouth on a regular basis and see the different issues that can arise from crowded oropharynx. I just want to say a couple things about worldwide obesity, because if you just look at the statistics from the beginning of this decade, it's an enormous problem. I shouldn't use that word, enormous, but it still is. Almost 2 billion adults 18 and older are overweight. That's almost 25% of the world population. Yes, there are areas of scarcity of resources, but in industrialized countries, we're seeing this explode onto the scene. And it's not new, and it's only getting worse. And we could say obesity is a disease of civilization, and the more we become industrialized in different areas, the more you're going to see this as a problem. You could just look at the statistics are really sobering. That's worldwide. But I wanted to show you a map from 2011. This is the United States with this, what's called the BRFSS, which is the Behavioral Risk Factor Surveillance System, which was just a bunch of phone calls made to different in different states by the CDC, and asking people, questions about their health. How often do you go to the doctor? How often do you go to the dentist? And one of them is your height and weight. So for people with a BMI greater than 30 as calculated, or 30 pounds overweight. And they just ask people, what is your height and weight, and and we'll calculate this. And in 2011, if you look around, that about 25% was the majority of people in these states that have what would be considered obesity, not morbidly obese, but just obesity. So there's all gradations. And you see in this area of the country, you were getting 30 to 35%. Now, there are interim maps that show this getting worse and worse in many states, but I'll just show you the last one that came through. And this one should be sobering to a lot of people. You're looking at, I think the sleep conference that Michael is at is in Louisiana. You're looking at you're getting close to 40 to 45% of people that were surveyed. Now, that doesn't include everybody, that are obese, an enormous risk factor for sleep disorder breathing. And I just want you to keep that in mind as we move in the next, several years and decades, because this is a problem. And you see that areas that were yellow or green are now in the 35 to 40% range. That's an amazing number. But even though sleep apnea is risk factor, the biggest one is obesity. Not everybody with morbid obesity has sleep apnea, and not everybody with sleep apnea has morbid obesity. So if you really look at the percentages of those with the BMI is greater than 30, yes, as you get to more and more severe sleep apnea, you're getting more and more percentage of people in that category. But if you look at those with an AHI greater than 5, mild sleep apnea, patients with a BMI less than 25, normal rate 20 to 24, still close to 15 to 20% of that population. As you get into the moderate sleep apnea, still 10 to 15%. And this number is probably closer to 10 to 15% in terms of people with severe sleep apnea have something other than obesity that is driving their sleep apnea. I think it's very important to understand. We all have seen this or used this in our practice, just looking at oropharyngeal anatomy as one of the risk factors for sleep apnea. So obviously, if somebody has a Mallampati of 4 and you can't see anything in the mouth, there's not a lot of airflow going through this on a regular basis. You know, open doesn't mean you can't have sleep apnea or a risk factor for sleep apnea, but it does mean that you have less of a risk. So what's the whole system that leads somebody to sleep apnea? Well, there's physical anatomy, there's nasal anatomy, there's oropharyngeal anatomy, there's global anatomy, and then how your brain deals with that and how it ultimately affects the system. And we'll talk about loop gain in a second. And there's plant gain, which is how the physical body handles it, and controller gain is how the chemoreceptors, or how you deal with carbon dioxide or oxygen levels, or how the receptors handle the stimulus that's being put into the system. So what's the pathophysiology of sleep apnea? Well, we can, you know, when I talk to patients in the office, or when you guys talk to patients, you know, you say, well, it's when your airway collapses. Yes, there's reduced airway tone. There is diminished reflexes to protect the pharyngeal collapse, which may be an age-related phenomenon or just a phenomenon in those with neuromuscular diseases or other issues related to brain physiology. And there's an inability in certain patients to not be able to handle the stimulus that's happening. You say everything looks normal, but if you stress the system, it can't handle it. So what is loop gain? And I want to introduce this to you because you're going to see this in the literature. The more you delve into the pathophysiology of sleep apnea, you're going to see this these terms. Loop gain has been borrowed from the engineering world to see how a system responds to a stimulus. And I alluded to this a second ago, but plant gain is how the physical system responds. Does it expand? Does it contract? And then how does the feedback loop in the chemoreceptor system respond? All you really have to know is that loop gain is how the system responds. The minutia is how the physical system and the chemoreceptor system responds. And any derangements in these systems leads somebody to have apnea, and then ultimately, if it rises to the level of pathology, to have sleep disordered breathing. And even about 10 years ago, maybe even a little bit further than that, this idea of looking at, you know, are there other targets besides just, oh, you have a collapsible airway and we'll just put a trach in and bypass it. Well, there has to be other things that are associated with it. So this idea of P-crit we'll talk about in a second, is critical airway pressure. And that's the pressure in which the airway can no longer stay open and collapse. And it's different for different people. And we'll see where this has implications in the lateral and the supine position. But there are also non-anatomic contribution to obstructive sleep apnea. There's the nerve responses in the central nervous system and to the muscle, and that's related to plant gain and loop gain and chemoreceptor and controller gain. The reason I say this is that you're now seeing more and more emphasis on other parts of treating sleep apnea. And this is some of what the Inspire devices and other devices that help other forms of sleep apnea improve. Arousal threshold, so how quickly somebody responds to a stimulus, how their body responds to the insult is an important other. And then we talked about loop gain and its role in sleep apnea. So how does the whole system work, and how do we simplify it so we understand what this means? Well, in a very easy engineering way, you have a sealed box. This is your neck, And this is your musculature and the nerves that supply it. And on either side is your oropharynx and really your chest and anything below the oropharynx, below your vocal cord, or really not below your vocal cords, but really below your neck. So this area you see is not very big and it can collapse really easily. But how do we hone in on this, and what are the things that can cause sleep disordered breathing? Well, you're going to see this in the literature more and more. This is what I alluded to before. And the peak crit is the pressure at which the airway can no longer stay open and collapses. It measures the collapsibility of the pharyngeal airway. And when those areas around the tube get too much, or you don't get enough into the system, you ultimately get a collapse of the airway. And that's what an apnea or a hypopnea is. You may get total collapse, or you may get partial collapse. And this is the important thing. This took me, hours and hours to remember, but I want you to remember that the lower the peak crit, the less collapsible the airway. The more the measurement is more negative, is less collapsible. And the higher the peak crit, the higher pressure there is, it's a more collapsible airway. So just keep this in mind. More negative is better, and you'll see that in some of the physiologic studies. So what I alluded to before, you have rigid tubes on either side of your oropharynx, and your musculature around it, and this collapsible area. If the pressure coming in is high enough, it will keep the airway open. If it's not negative, if for some reason there is a point at which it drops and the downstream pressure is less, you'll get a collapse. If that's one condition. And that can be morbid obesity, that can be neuromuscular diseases, that can be other neurologic syndromes that don't allow you to take big, deep breaths. This other condition is when you don't have enough coming into the system to overcome this collapsible segment. So this could be nasal congestion, a very high malinpipe, big tonsils. All those things lead to you can't get enough pressure through the system and it collapses. But if there is enough, if we put more pressure in the system, or we allow the rest of the system with more and more pressure into it to overcome this internal pressure, that's when this airway stays open. That's one of the principles behind CPAP. And we'll see where that comes into play very, very soon. So just remember, I just put this as a duplicate slide to remember that these are upstream conditions. If you have this airway, you may not be able to get enough airflow into the system to overcome the pressure needed to keep that airway open. And obviously, when you fall asleep, everything kind of collapses, everything kind of relaxes. So this is an awake patient without their tongue out. So what are the treatment options? And I want to talk about a little of them so to understand the physiology and why some of them work and some of them don't work. I think there is a feeling in some parts of the sleep community that everybody with sleep apnea, no matter the severity, should get positive airway pressure. Now that could be CPAP, that could be bi-level positive airway pressure. Remember, BiPAP is a proprietary term. And then we use a lot of auto-titrating CPAP, a lot of auto-titrating bi-level positive airway pressure. We have other targets, adaptive servo ventilation. We have volume targeted pressure settings. We have dental devices to open up that upstream area. Weight loss, we'll talk about in a second. We'll talk about medications. And obviously, because of this talk, we'll talk about positional therapy. But I want you to understand where it fits into the whole system. So we all are familiar with PAP therapy. And if we're not, this is the mainstay of treatment for sleep apnea. And where does it work? Well, we talked about the a little bit about those those three conditions. You put in enough pressure into the system and you keep this airway open. Now you can have a little bit of downstream effects from enough pressure to put in some volume into the lower respiratory tract. But for all intents and purposes, we're trying to overcome the upper airway and this oropharyngeal airway pressure. But here's the, I can't hear anything on the other end, but I hope some of you are a little bit, chuckle a little bit at this slide, because this is one of my favorite slides that I created. PAP therapy or positive airway pressure can be effective, and people have this face on, when they put their CPAP on, like, it's okay, it's working. Other people feel like this, and, is it tolerated? And then others feel like this is what they feel like the entire night. So when you look at therapies, yes, they can be effective. And yes, they might be tolerated. And yes, they might be compliant, they may not. But put this all together, and is it the right therapy for somebody? Somebody who's not going to use the therapy because they can't tolerate it, it doesn't matter how effective it is. And these are the things that we have to keep in mind, because I think too many people use CPAP as the only therapy. So what are the upstream therapies? And many of you may have seen these, but I want to touch on them for a second to understand their physiology. They work on this area. You open this, you're not putting any more pressure and you're not adding any positive airway pressure, but you're opening up the area to see if we can keep that open, and the pressure that exists in that individual patient, that negative pressure that they're pulling in, will be enough to overcome the need for this segment to collapse. So this is one of the interesting therapies. I know it goes by a different name now, but basically what it does is it sucks out the soft palate and tries to open up the airway. Not very well tolerated. And I just was informed yesterday, because I haven't prescribed this a whole heck of a lot, that there's a ton of saliva. And so you have maybe a slightly effective therapy that's not well tolerated, and not many people are going to be compliant with it. This is part of their marketing material, and I never understood. I took a bunch of their snapshots off their website when it was available, but I don't know. It kind of looks like he's being fed nitrous oxide or something and causing all these like hallucinations. Maybe LSD or maybe some other substance was helpful in getting him a good night's sleep, but I'm not sure Apnea was the best therapy we could find. But it has an effect on the upper airway just to keep it open. No pressure exerted. Provent, which was an interesting device for mild sleep apnea, and even some with moderate, and for snoring. But what it did was it created a negative pressure in the upper airway, in the nasal passage, that would be translated down through the oropharynx to keep that airway open. And if you open your mouth, it didn't work. And the important thing is, it may help you to snore less, but it wasn't really effective for sleep apnea, because it didn't really do anything enough to the physiology. This I kept in for various reasons, because I think there is this always prevailing notion that your tongue is sliding back, and there was an idea that maybe your tongue wasn't strong enough, that the genioglossus muscle wasn't strong enough, and it may be a target, but this was only really indicated for snoring. You had to use this device at least twice a day for several weeks to start to see an effect. All it does is causes electrical stimulation. It's like a TENS unit to strengthen those muscles. Not sure it worked very well, and I haven't prescribed this or been enthusiastic about this, but you can see where the physiology may be targeted here. This is an interesting device that I have never really seen in use, but this is my favorite picture because this is exactly what it does. You slip your tongue in here, you put this in front of your teeth, and it holds your tongue out to open up that airway. I don't know how comfortable this is, and I'm not sure it's really that effective. And certainly could dry out portions of your tongue that are sitting outside your mouth, and then you can't really close your mouth to swallow. So a lot of saliva as well. So not a very popular device, but you see where the attempts at targets were. The ultimate controller is your brain, and all the loop gain that exists comes from your brain and translates down into your upper airway. It's important that this is now being used as a target in many different medications. So this is an older slide that I updated, and these are some of the brain or medication targets that they've tried to use to see if we can shorten apnea, get rid of apnea, increase the respiratory drive. Acetazolamide we still use as a diuretic. We used in altitude sickness, but it increases respiratory drive. So the thought was, well, if we can increase respiratory drive, we can increase the physiologic mechanisms that are making you take deeper, more rapid breaths and overcome that collapsible segment. Not a whole heck of a lot of success. And you can see these studies are 25, 30, 40 years old. Almotrine, which we don't use a whole heck of a lot, is also a respiratory stimulant and works on those controller gain and sensitizes the carotid body receptors to decrease the duration of apnea, which may or may not be a target of helping people feel better with sleep apnea and looking at the arousal thresholds. Medroxyprogesterone is a central respiratory stimulant and may help sleep disordered breathing, but has a lot of side effects. And those women who take estrogen replacement after menopause may do slightly better with their sleep apnea than their male counterparts or even their premenopausal counterparts. The GLP-1s have huge amount of press right now, but overall cause a lot of weight loss and affect the brain more so than they do the gut receptors. And the Mariposa trial is still in progress, moving to human trials or longer human trials, and it's a stimulant and an anticholinergic that seems to lower the apnea hypopnea in select populations. We'll see where that goes, but you can see that they're not just using CPAP or positive airway pressure to get rid of sleep apnea. There's a lot of different targets. So what's the obesity influence? Well, it has an effect on everything. It has an effect on the muscles around it, your lower respiratory tract, your upper respiratory tract, and your brain. And I just put this slide in because this is just an interesting idea about the lower airway. So when you sleep, the lung mechanics are affected. You get lower airflow resistance, you get lower functional residual capacity, and you have different blood flow to oxygen relationships. And that can lead to hypoventilation, to desaturations, which we see in the lab a lot. You can see hypercapnia and how does the body respond to that. And you can see airway collapse. And it has an effect on the lower airway, as I said. So does weight loss make any difference to sleep apnea? Well, the bariatric surgeons will toot their horn, as well as the makers of GLP-1 and one of the GLP-1 drugs has gotten approval for obstructive sleep apnea because of this original study, and there have been many since then, but I left this one in because it's about 25 years old and been looked at for the last 30 years. And they just looked over a 4-year period. And when we talk to patients about weight loss, I always tell my patients a 10% decrease in your body weight shows me a couple things. One, it has an effect on your AHI, and it also shows me commitment. So if you're 300 pounds, I don't want you coming back to me and said, I lost 7 pounds, I need a new sleep study. What I think is that physiologically, 10% shows me a physiologic change, and it also shows me commitment. But also the reverse is true. As you get heavier, there is a semi-linear relationship to worsening sleep disorder breathing. So the last, I hopefully that makes sense to everybody in terms of where our targets are and where the physiology of the upper airway has a role in leading to sleep apnea, because it's a multifaceted idea. There's a lot of things contributing to the airway collapse. But what does position have to do with it? We know the supine position has an effect on your lung physiology, your upper airway physiology, but does it lead to sleep disordered breathing? And the answer to that is obviously I wouldn't be lecturing on it if it didn't have an effect. So what's the definition? You're going to see this 𝐼𝐿 term. Exclusive positional sleep apnea is defined as the supine apnea-hypopnea index that's greater than 2 times the non-supine, and the non-supine is in that mild range. So you'd like to be less than 5, but less than 10 is definitional. So you pretty much resolve your sleep disorder breathing into at least the mild range and sometimes completely gone. That's EPOSA, or exclusive positional sleep apnea. And you'll see this in the further studies. And the positional sleep apnea is twice the non-supine AHI, that with a non-supine sleep or apnea hypopnea index greater than 10. And we've all seen this if we've looked at sleep studies and you say, wow, it really looks like their numbers are higher in the supine position, but their AHI in the non-supine is not less than 10. So they still have close to moderate sleep apnea. That doesn't mean it can't be a target of what you do, but it may not, with a positional device, resolve their sleep apnea. So what's the prevalence? Well, if you just look at a study that's been done over the last 5 years, they looked at about 1,800 subjects, and they defined sleep apnea or positional sleep apnea the way we talked about it. They had 70% had mild sleep apnea, and those with you had those that had positional sleep apnea, at least 50% of these subjects, and 75% of the people with sleep apnea had positional sleep apnea. And if you looked at just exclusive positional sleep apnea, you were looking at 26% of all the subjects, or at least a quarter, and almost a third had just pure positional sleep apnea. And if you're just using CPAP or other devices that don't take this into account, you're missing a therapy, is the take-home point that I want you to be aware of. So does it increase with severity? If you just look at the mild to close to moderate range, yeah, you have more and more positional component as you get in higher and higher severity. If you just look at all the way to severe sleep apnea, if you look at just exclusive positional sleep apneas, you still have a percentage that have severe sleep apnea that's all positional. And some people don't, start to think there's no way this person with severe sleep apnea could be severely positional or only positional. But if you ignore that on the sleep study, you're missing a target that may be well tolerated versus something that isn't. So you also see that in the mild to moderate range, enormous amounts. And even in the severe range, you still have positional sleep apnea. So if you're not reporting this on your sleep studies, you're missing a huge diagnosis. Now, if you just look at CPAP, and we talked about people who can respond, is it effective? Well, they respond to it. Yeah, most people will respond to CPAP. But if you look at just adherence in an odds ratio less than 1, they're not really adherent. And their treatment success, which was defined as lowering your AHI and lowering your Epworth score, a measure of how sleepy you were, not very good. You know, it's okay here, but not very good. So you may be missing a lot of positional sleep apnea, and you may not be treating it very well using just CPAP treatment or PAP treatment. If you look at age and if you harken back to what we talked about in terms of loop gain and controller gain, and the brain being the major controller, as you get older, the brain doesn't work as well. The muscles don't work as well. Well, if you just look at greater than 65 years of age, if you're looking at positional sleep apnea or sleep apnea with that's EPOSA, that exclusive positional sleep apnea, you see that greater than 65 years old, you still, compared to those who are younger, much more positional sleep apnea. So if you have patients that are elderly and not tolerating CPAP or other therapies, you're best served by looking at this as an entity. So why does it happen? Well, Earth has gravity. You have load onto your chest. You have load of gravity onto your upper airway in your neck, to your tongue sliding back. All those things contribute to your positional component. Now, we could put you on the moon with less gravity, and we'd all weigh less on the moon, but we're not there yet, no matter what Elon Musk wants to do, or if he wants to go to Mars or he wants to go to the moon, less gravity would help. But since we can't get away from gravity, maybe changing positions may help. So here's a whole bunch of devices. And it's nice to be able to tell people, well, you have positional sleep apnea, just sleep on your side. And sometimes you can do it with some of these interesting pillows, but they look kind of uncomfortable and I feel like you're trapped, but that's just my feeling. So if you look at just some devices, you can see how they stop you from rolling over on your back. Now, each of these has its own efficacy. There was an old tennis ball in sock therapy where you put 3 tennis balls in a sock and then you kind of pin it to your back. Well, with memory foam mattresses, I think sometimes this device or the tennis balls or this device has a tendency to sink into the memory foam and it doesn't work. There are other devices that have a belt around here, around your chest, that measures where you are in space, and has an alarm associated with it that either wakes you up audibly or can wake you up by a collar around your neck that ultimately gives you a little bit of a shock, kind of extreme therapy. If you look at some data that was in the last several years, looking at, and it takes you a little while to know what these abbreviations are. This is light sleep, slow wave sleep, and REM sleep. You can see the P-crit, you can't really see it as well here, but it becomes, in a lot of subjects, more negative, and it's more pronounced in REM owing to a lot of different factors. But you can see it's not unbelievably different, but enough that it can cause the P-crit to be less collapsible. You see in this one subject, it's a godsend. But if you look at just flow, you see a better relationship. This is lateral position, so open circles, and you can see light sleep, slow wave sleep, REM sleep. What is the flow that exists? And you see more negative flow is less collapsible, and you see in all stages of sleep much better than the supine position, owing to all those factors I just talked about. So does it compare to CPAP? in its efficacy. This study was done approximately 10 to 15 years ago by my colleagues at Temple University Hospital at the time, and just looked at CPAP versus a positional device throughout a bunch of severities of sleep apnea. And you see, really, you can get the AHI less than 10 in many subjects and less than 5 in a lot of patients, comparable to CPAP. As I said, CPAP works very well for people, and you can see it here, getting the AHI less than 5 in most of the subjects, but a positional device that may be more well tolerated and is just as effective. Night Balance is another positional device that had a belt and an alarm, and they looked at the efficacy between auto-titrating CPAP, which we use a lot, and this positional device. And they did a non-inferiority trial. And you can see, yeah, you can start to pick apart the error bars, but you can see from baseline that auto-titrating CPAP does a good job, and also below an AHI of 10, that it does a decent job overall. In REM sleep, may not be as pronounced an effect, but overall a very good effect. So they saw that this is maybe a treatment option in patients that don't like auto-titrating CPAP or don't want to use auto-titrating CPAP. Can you use it in combination? Well, you can. I don't think it needs to be an exclusive therapy in any of the sleep apnea treatments. So can it be used as CPAP? Yes, I've used it to lower CPAP pressures, to make them more tolerable for certain patients. You can use them with upper airway surgery, with dental devices, along with medications, and obviously alongside of weight loss. And if you look at just one study that was done probably about 6-7 years ago, and it was a small study. It looked at therapeutic effectiveness after upper airway surgery and using a positional device. This median effectiveness was a measure of better compliance plus less sleepiness. And it increased from this 39 or almost 40% to almost 65%. So showed a trend toward people felt better and did better when you combine the two. I just wanted to touch on cost of treatment. The American Academy of Sleep Medicine says the cost of ongoing CPAP with repeat studies, with supplies, new machines, comes out to about $2,000 per year, a little bit more, probably between $2,000 and $2,500. And this is a study that I was involved in that was published about 5 years ago, looking at a population of firefighters within their insurance company, and they were looking to lower costs. So if you look at the cost of initiating auto-titrating CPAP, it's about $1,000. To use this proprietary device, this Zzoma, costs about $200. There are no ongoing costs with this. So this may be $2,000 a year for the next 10 years if nothing changes. So you're talking about $20,000 versus a $200 investment, or somewhere in there, and it wouldn't be comparable to $20,000 to even $1,000 if you had to replace the device a couple times just for wear and tear. So hopefully that gives you a good idea of the physiology that's involved in sleep apnea related to the upper airway, how these devices fit in, and how positional therapy or positional sleep apnea fits into your algorithm. I put this into a lot of my presentations just so I think it's funny and interesting. There are a whole bunch of sleep products out there. And one that has always caught my eye, it's by a company called the ostrich pillow. And literally you put your head into this and you can nap. You can put your arms into it. I just love their marketing pictures, because I don't know who sits at the bus station or the airport and sits like this. I mean, someone's going to steal his bag. And then they say, even you can use it at work. So I know a couple people that have this. I don't know how much they use it. It has nothing to do with positional sleep apnea or sleep apnea treatment. I just think it's fun to peruse all the products that are out there that help people sleep better. And I think that's really all that people want, is to sleep better and have options. So to conclude, I think, you say, why does this say happiness? Well, I think treating sleep apnea is a little like trying to make some people happy. It's not a one-size-fits-all idea. The idea, how they define happiness is, do they feel better? Is their AHI less? Are they compliant with the therapy? Does it help them lead a better life? I think giving them options to get to that goal is important. It's not, as I said, it's not a one-size-fits-all solution. Obesity, upper airway anatomy, which many of you on the call are maybe dentists. This is an important and sometimes overlooked area. And these are other targets that are being looked at and may be used in combination with all of these other therapies to help people get to that effective therapy and be happy, less sleepy. Because that's what really we're looking at, is to be less sleepy may lead to a better, a decreased mortality. And it needs to be individualized and tailored. So anytime that you're sitting with a patient, you should be able to say, I think this would be good for you, and that would be good for you based on these criteria. Because if you're only offering CPAP, it's it's the old adage, if all you have is a hammer, everything else looks like a nail. And with that, I'll take any questions, and hopefully that took you on a good journey to understand why these therapies work and where positional sleep apnea fits into the algorithm and how effective it is. Thank you for listening, and I'll take any questions if you have any questions at the moment.
So we've got a question here from Ramesh Verma. Any role of nasopharyngeal exercises in OSA?
I think as adjunct therapy, anything that will help the entire system will work. I don't see a downside to any of that stuff. Looking at something like Provent, does Provent work, or whatever it's called now? It works as a small portion. So those nasal exercises, I don't see any problem with doing them. I don't think there's a downside to them. So my answer to that is yes.
Question from Gus Tanis. Are positional therapy devices covered under the average insurance plans?
They are getting their Medicare code. They haven't been, there is a Medicare code for them, but people were paying out of pocket for them. Some insurance companies were covering it to some degree, and I just heard from a couple colleagues that it's going to be a true code and will be reimbursed hopefully soon.
I think the ostrich pillow was a big hit. We should have had them sponsor the talk. I don't think I've seen that before. That thing's crazy.
They have a whole bunch of other products. I just thought that one has caught my eye more than any other one, because it has some utility, but I think they're using it for weird purposes. But go ahead.
Yeah, I think if you were out in the public with that, I don't think anyone would come near you. You'd probably be safe from any.
Maybe not from me. I'm too much. I want to cause havoc, but that's a different story.
Another question here: if someone has positional sleep apnea and PAP takes care of the AHI in a supine position, do you still recommend positional sleep apnea therapy? I would guess is the end of that question.
No, you don't have to. CPAP PAP therapy will work for positional sleep apnea, and it covers up a lot of those who may have exclusive positional sleep apnea that haven't been diagnosed that may be amenable to a positional device, but I certainly wouldn't move anybody to a positional device just based on the fact that they have positional sleep apnea and their therapy is working. If they feel good on their therapy, absolutely fine. I have no reason to push them. But if they come in and say, boy, I'm having trouble with my mask, I'm having trouble with, affording my machine, or I don't feel good, I think re-looking at their study or re-studying them, or, saying, you know what, you have positional sleep apnea. This may be an additional option for you, is absolutely fine. But I wouldn't push anybody off their therapy.
Any other questions out there, guys? If you have anything else, pop it in chat real fast. Getting a lot of really positive feedback on your talk in chat and the comments. Great presentation, great delivery style. Another great talk. We've had some really good webinars lately, and this is no exception. Thank you, Dr. Jaffe.
My pleasure.
Oh, we got a question. Are you still recommending BiPAP for patients requiring pressures greater than 14 centimeters H2O?
Yeah, it's a really good question. I have, there are a lot of labs with protocols that necessitate moving to bi-level positive airway pressure. And that is still, in my mind, controversial, because it's supposed to be better tolerated bi-level positive airway pressure than just straight CPAP. But that's not really been borne out enough on the studies of compliance or a long-term efficacy. So the answer to that is yes, but I always look at these studies because they invariably, not invariably, but many times they come back and say, you know what, it's still not comfortable. And then looking at other adjunct therapies like positional or dental devices, or maybe looking at their, that their nasopharynx and saying, boy, you know what, you've got clogged sinuses, or you need to see ear, nose, and throat, or you need to, do something with your upper airway, and we can lower these pressures. We have a tendency to think that CPAP will overcome everything, and it does. If you give enough, hell, I can put you on the ventilator and your sleep apnea will be cured. But that is not a reason or not a reasonable approach. We could trach everybody and then, this would be great, but that's not really the answer. And that's why I say you want to give people options. So if somebody's uncomfortable and say, you know what, BiPAP maybe not be for you, or bi-level positive, let's move to something else.
Final question, and then we're going to, after that, I'll put up the links again for the certificates. So final question here. Are you still, we got a lot of comments in here, so let me get to that, where that question was. Oh, here we go. Last question. For patients with EPOSA, should we consider positional therapy and not PAP at all?
I think this dovetails with the other question from before. Positive airway pressure devices will work for exclusive positional sleep apnea, but I think the answer is a little like, can you drive a race car on the street? Yes, but you don't need that. So if the answer is someone says, you know what, I like my CPAP, I feel good, I like this device, there's no reason to move them to something else. But if they have exclusive positional sleep apnea and you say, here is a positional device that you can wear, and let's see how you do on it. Is it better? Do you take it off in the morning, you got no marks on your face, you don't have dry mouth, you don't have to fiddle with a humidifier, you don't have to do all those things. This is an option for you. So I don't think you should eliminate any therapies, but try to figure out what is good for that individual patient.
We got a couple minutes left. I'm gonna do these two last questions because this one is important, because I'm not quite sure. Please, I'm gonna put it up on screen. It's kind of long.
This is the please forgive me one?
Yeah.
Okay. Yeah, I mean, yeah, this is that would have been a 6-hour presentation. So I think the answer to that is, yeah, we're talking about pure obstructive sleep apnea. And the complex sleep apnea patient, those with central apneas that are, and a patient who has other mixed disorders is a whole other ballgame. Yes, you can have positional obstructive sleep apnea and be put in the lateral position, and you can still have central apneas. That is a different therapeutic target and needs to be treated as such. So a completely different disorder.
All right, let's answer this last one, and that's it. I swear, I mean it this time.
Yeah. Okay.
And I think you just touched on this anyway.
Yeah. Can you still have hypovent? Yes. I think when the part of the reason I put a lot of that physiology in the beginning is because you start to understand the system and that it's not a perfect system. It's not like, could you drive your car on 3 wheels? You could, it just won't work as well. So the idea that in the lateral position, you still have hypoventilation, there may be 87 other reasons why you hypoventilate, which may not have anything to do with load on your upper airway, load on your chest wall. It could be any number of things. So you could still have those. The idea that there is even you can hypoventilate even on CPAP. But it's less of an issue, but you can. So lateral supine, you can still have hypoventilation. It's not as I said, it's not a one size fits all, or it's going to cover every disease.
All right. And I think we're going to end it there with Dr. Jaffe. Dr. Jaffe, thank you very much. Great presentation, great feedback from the attendees, and I'll switch you off screen.
My pleasure. Hopefully we can do this again sometime soon.
Yeah, thanks. Take care.
Thank you.
All right, guys, we are back, and I'm back here in New Orleans still. So let's drop in the certificate for RPSGTs. Now, that's the link to fill out the Google form. Some of you aren't able to fill out Google Forms from your facility. Let me give you either my email address, and you can email me and we can send it to a different address, like a personal address that you have, so you can fill that out. If you like texting, it's just as easy, 267.419.7990. I'm typing and speaking at the same time. You can text me if that's easier for you. That's always quick. Send me that. And you will, once you complete the evaluation from that Google link, you'll get your certificate immediately. If you don't see it, check your spam. That's always a consideration. Now, for our CME folks, I put this up earlier. This is for our physicians and dentists. Hang on. Actually, let me go back to that, but let me put this up here first. Coming up at the end of the month, we will have it's the same presentation on 2 different days. Oh, man. That is the link to the upcoming webinars. When we do, there's a lot of comments about having this accredited for respiratory therapists and sleep technologists. Typically on the sleep webinars, we're doing them strictly for sleep, and on the RT webinars, we're doing strictly for RT. That's just kind of the way we're doing those right now, and I don't know if that's going to change, and I apologize. We always put in the promotional materials what these webinars are accredited for. And let me just scroll up one more thing. We'll get the link in here again for And I'm not in the studio, so it's a little hard here when I'm on the road to do all this on one little laptop. So just bear with me. And for our CME folks, here is your link again. Okay, so all the links are in there. I want to thank everyone for being here today. We love providing these webinars. And if you have any questions, use my email address or my text number. That's a business text. You can send a message at any time. And that's it from here. That's it from here in New Orleans. So we'll see you on the next webinar. Thanks for being here.